everyone, welcome back to our Children's Palliative Care Special Interest Group case presentations. I'm Dr. Drace Ng from HCA Hospice Care, Singapore. Our case for discussion today is patient A, a newborn boy with antenatally diagnosed gastroschisis. He is the first child to a set of non-consanguineous parents. The growth scan at a gestational age of 22 plus 4 weeks showed a very significant portion of the gut was out of the abdominal cavity. Parents were counseled by the pediatric surgeons regarding the diagnosis and also possible outcomes. And parents decided to continue with the pregnancy, hoping that the child's condition would be operable after birth. In terms of the birth history, patient A was delivered via emergency lower segment cesarean section at 34 weeks gestation due to premature prolonged rupture of membranes with persistent contractions. A course of dexamethasone was completed. The baby was vigorous at birth with an UPGAR score of 9.9. Gastroschisis was confirmed as examination revealed an abdominal wall defect with evisceration of bowel. The baby's birth weight was 1.8 kilograms. Patient A underwent emergency exploratory laparotomy at 6 hours of life. Intra-op findings revealed a complete mid-gut strangulation from the third part of the duodenum, D3, to the distal transverse colon. The exteriorized bowel was ischemic and non-viable. Proximally, there was a distended stomach and megaduodenum, and distally, there was 10 cm of colon leading to the rectum. This was deemed a non-viable configuration and that the patient was not a candidate for gut transplant. Hence, a decision was made by the surgical as well as the neonatal teams for palliative management. The extruded bowel was reduced into the abdomen with fascial closure. So parents were counseled regarding the poor prognosis, which ranged from days to short weeks, and though grieving this outcome, they were accepting and agreeable with palliative management. They wanted to bring their baby home. The pediatric palliative home care team was activated to support this family at home. Upon discharge on day 4 of life, patient A was alert and opening eyes, comfortable on IV morphine infusion of 4 mics per kilo per hour via a peripheral line. He was kept nil by mouth except for small amounts of colostrum for comfort. He had a nasogastric tube in situ, which was being aspirated 4 hourly, yielding 1 to 2 mL of bilious contents. Patient A's abdomen was soft, not distended, and non-tender. The surgical wound site was clean with small amounts of clear discharge from the umbilicus. There were no other congenital abnormalities. For this case, I would like to post up the following questions for discussion. Firstly, how would you prepare for this baby's terminal discharge? What symptoms or complications would you anticipate for, and how would you manage them? How would you prepare and support the family and also the healthcare providers on the ground for these possible scenarios? What are some special considerations when providing palliative care to premature babies? And lastly, what are some ethical issues to consider in this case? For example, would you consider continuation of IV fluids or TPN, total parenteral nutrition at home? Is it appropriate to approach these parents regarding organ donation? Please feel free to also share any of your experiences in managing such similar cases. I thank you for your kind participation and we hope to hear from you soon. Thank you.